Alrighty, we've made it to the very last session. Welcome to the final conference session of the day titled Living with Chronic GVHD. My name is Nyari Sireu, Patient and Professional Programs Coordinator. As we get started, AMDSIF would like to recognize the generous support of our corporate sponsors. At the diamond level, we have Novartis and Alexion, and at the gold level, we have Apellis and Genentech. We would also like to recognize the generous support of our patients, families, caregivers for supporting the conference today. Immediately following the session, we will have a question and answer segment. And when you ask your question, I do ask that you do not share any private health information, as our specialists cannot answer any specific questions related to your healthcare. Today's specialist is Karamjeet Singh Sandhu. Dr. Sandhu is assistant professor in the Department of Hematology and Hematopoietic Cell Transplantation at City of Hope. His area of interest include leukemia in the geriatric population, immunotherapy, graft versus host disease, and the impact of microbiome on hematopoietic stem cell transplant. With that said, it is my pleasure to welcome Dr. Sandhu.
Good evening, everyone. I think now that we are all refreshed after ice cream. But no, thank you for inviting me here. It's kind of a great opportunity to share our experiences, and it's kind of one of the very challenging experience after the transplant, dealing with this long-term complication. But I will try to keep it simple, and I can just stop me anywhere where I'm not very clear. So I will go through like a basic concepts: graft versus host disease, potential causes, classification, sure, and how it may present, and potential treatment options that could be considered. So, the stem cell transplant, as we all know, is one of the most potent immunotherapy. And as a physician, I think it's a challenge for us to kind of balance on the one aspect, the disease, patient-related characteristics, and to kind of translate those into some of the outcomes related to the relapse, improvement in the graft versus host disease, and obviously at the same time, decreasing the infection and eventually improvement in the morbidity and mortality related to this intensive treatment. This is the kind of, since we're going to talk about graft versus host disease primarily, and the graft versus host disease and the graft versus leukemia primarily go hand in hand. And the slide here, if you look on the bar that is upright on the left, is depicting the relapse, and one on the below is depicting on the number of the months since the transplant. And the curves, the lower curves are depicting the risk of graft versus host disease, and upper curves are depicting the patients who have received the transplant from the twins or had T cells removed from their graft source. And if you see the patients who had chronic graft versus host disease or chronic graft versus host disease along with acute, has a lower risk of relapse. So it's kind of a double-edged sword. In one side, you're asking for graft versus host disease to improve on the risk of the relapse, but at the same time, this is what we have to challenge on the daily basis to how to balance it against the outcomes of the transplant. And basically, what is graft versus host disease? It's an immune reaction which is triggered by the donor cells toward our own cells, recognizing them as a foreign. And we use several immunosuppressive medications to prevent these reactions till the time we hope that donor cells will eventually develop some sort of tolerance toward the foreign cells, which are our own cells. And the factors that can contribute to is if the match of the graft, if it's a non-identical, and the gender mismatch, and depending on what prevention regimen we are using, and intensity of the conditioning regimen, and the source of the stem cells, like peripheral blood cells, will likely have more graft versus host disease compared to the bone marrow graft. And lately, we have been learning about this whole colony of the microorganism that live within us, and depending on the health of the microorganism, that could be associated with the risk of graft versus host disease and its outcomes. And slide basically here is depicting the incidence of acute graft versus host disease. And if you see the one on the left is the sibling donor, about 40% of them will develop graft versus host disease. And I mean, you can imagine the sibling donor is the perfect match. You can still, about 40% of them are still having a graft versus host disease. And in comparison to the unrelated donor, it goes up to the 60%. And then there's a spectrum of the graft versus host disease where you have a late acute, findings of acute, more than 100 days, 10% of the patients may present with that. And then there's a chronic graft versus host disease, which is more than 100 days post-transplant and present in about 50% of the patients. So various strategies are used to prevent these complications. Several combinations are being explored. Tacrolimus methotrexate is still available. I think it's been around close to 20 years. And lately, for the past 10, 15 years, we've been very often using combination of a post-transplant cyclophosphamide, tacrolimus, and mycophenolate, and later, and the studies shown have very impressive outcomes in regard to the chronic graft versus host disease. At City of Hope, we often use tacrolimus and sirolimus, and patients, if have a compromised kidney function sometime, we use combination of post-transplant cyclophosphamide along with sirolimus to replace the tacrolimus, which has a toxicity toward the kidney. And very often these days, initially we used to use the complete T-cell depleted product, and the association was with if it is contributing to more infections, more relapses. But lately there has been kind of I would say some sort of a partial deletion of the T cells, and one of the graft that is now available is ORCA graft and is being studied in several trials, including at City of Hope. And then my personal is the clinical trials with the microbiota modification among the transplant recipients. So acute or chronic graft versus host disease, what is it? So timing. I mean, technically this timing was developed for the classification, but there are some specific symptoms that can split them. But for the classification purposes, we go with less than 100 days is acute, and after the 100 days is chronic, and sometime it can overlap between both of them. And the pathology in the acute is acute destruction of the organs as a result of inflammatory T cell process. And the chronic is more like an abnormal repair leading to this fibrosis, scarring, and symptoms as a result of it. So in acute, you primarily deal with skin, gastrointestinal tract, liver, but when you're dealing with the chronic, it could be eyes, it could be gastrointestinal, it could be skin, joints, muscle, lungs, liver, kidneys, and genitalia. It's a wide range of spectrum. The slide here depicts the spectrum of chronic graft versus host disease depending on the percentage of the organs involved. The skin is the most common organ affected, then mouth, eyes. But I would say if I take from the mouth to the gut and the liver together, in my mind, I consider gastrointestinal tract as a whole is one of the major organ that is involved. And again, if you see that in the gray is the bone marrow graft and the blue is the peripheral blood, and if you can see that the patients who have received bone marrow transplant instead of peripheral blood, the bars are slightly smaller, showing that the risk of the graft versus host disease is slightly less. And we'll start with the skin GVHD, basically. I mean, when we think about the skin GVHD, we think about the anatomy of the skin. And so we kind of divide it into the 4 layers. What the topmost layer is called epidermis. Then the one below is the dermis, where you have all these hair follicles, glands, and sweat glands, and all that. Below that is the subcutaneous, which is mostly fatty tissue. And then below the subcutaneous is the fascia. So depending on which part is involved, that reflects into the symptoms of the graft versus host disease. So I think I will try to make it simple to say deep involvement, superficial involvement. So deep sclerotic, so it's the deep tissue involved. And what you have over here is the top left slide is morphia, when the graft versus host disease is primarily in the sclerosis or fibrosis or scarring is involving just a part of the any extremity or the body. And the same on the slide, same on the picture in the middle, it's just involving the distal wrist. We don't know why it just chooses one part of the body in comparison to some other patients where you have more diffuse involvement. And if you see the picture on the right, uppermost, you have more diffuse involvement of the abdominal wall and the chest wall involvement, and the patients will have a difficulty breathing because chest expansion is not happening, and they will often complain that they feel bloated. But in fact, it's not like they're getting fat, it's just the tissue is just getting scarred. And the one on the left below is what you see is in the dimpling in the extremities. That could be sometime because it is in the hidden areas, so the patients may not notice it till late when it has impacted some of the range of the motion. And the one in the middle, patient trying to do the prayer sign, and due to the scarring, the contractures have developed and is not able to bring the hands together. And this tissue is very fragile. Like once any ulcers or any injuries happen, they take forever to heal. I mean, I remember about a patient here, I mean, who happens to be a very a scientist who noticed that he has developed graft versus host disease while during one of his swimming session. He did not swim for 6 months, and then he went to swimming, and that's where he noticed that he cannot move his hands that well anymore. Came to us, and that it has creeped underneath. So then this is a superficial involvement. So the two main components here is one on the left is a lichen sclerosis, and one on the right is the lichen planosus. So lichen sclerosis is more like the skin has this texture of the cigarette paper, very frail on the left, and the lichen planosus is more the thickening of the top part of the skin, and it can present as more like a purplish papules. And then these pigmentary changes, in fact, this is perhaps the most common presentation of the skin graft versus host disease. And it's as a kind of a sequela of the onslaught of the graft versus host disease on the melanin producing cells or the pigment producing cells. And the distribution varies from person to person, body to body. And depending where this damage happened, that can describe if the patient is getting hyperpigmentation at some place or one is getting hypopigmentation. And then hair and nail changes, the nails are pretty much the extension of our skin with a stem cell hidden under the edges. So when the damage happens, they are very hard to treat with the distortion of the nail and kind of affecting the patient's self-image. Occasionally, we can use some steroids in the nail beds, but the response are not very promising. And on the right side, what you see is a hair loss. It is a more dramatic picture here. It can be a very patchy alopecia, loss of hair. It can be a diffuse hair loss, and depending on the amount of the sclerosis where the hair follicles are present. So the management could be a use of topical steroids or non-steroid treatment available. Moisturizers, although one may not think about it, but you have to still keep monitor the health of the skin to keep it moisturized from breaking down and then getting scarred, then getting infections which are not healing. And then systemic steroids, they've been around and perhaps still one of the very potent treatment if used appropriately in combination with some of the non-steroidal treatments. Phototherapy has been around. I think it has to have a special place, specialty to administrate. So it is kind of losing the value that it may have provided in the care, but it's still around in some of the specialty centers. Photopheresis, I will talk down the line toward the end of the slide. It's still very valuable treatment in some of the advanced form of the sclerosis. Physical therapy and rehabilitation, I feel like, at least in the sclerotic or a form of the graft versus host disease, I cannot emphasize how important is the part of the physical therapy and occupational therapies to work with us. To the fact that we've been collaborating with some of the physical therapy and rehabilitation physicians in the community to help train them to partner with us to improve some of the stretching and to help patient kind of adapt or accommodate to the muscle mass loss or everything that is happening so their functionality still could be sustained. And then obviously looking for the secondary cancer, this is already a distorted tissue with very high risk of the secondary cancer, both because of the underlying disease and some of the immunosuppressive medications we're using. Then moving on down the digestive system, and going from the mouth, saliva-producing glands, food pipe, stomach, gut, liver, pancreas. So it's a huge organ function that could be impacted by graft versus host disease, and it varies from patient to patient. Symptoms of graft versus host disease, if mouth, oral dryness, ulcerations, pain, gum bleeding, esophagus, food pipe, which is mostly in the chronic, difficulty in the swallowing if you have strictures, painful swallowing, choking on the food, choking on the pill. And if your stomach is involved, it can happen in both acute and chronic, abdominal pain, weight loss, things are not getting absorbed, appetite is being lost. And if you have a small and large bowel involvement, loss of appetite, again, abdominal pain, weight loss, diarrhea, bleeding, constipation, could be any. And the pancreas, again, valuable enzymes being produced for the digestion of the food, and when they are not being produced, leading to indigestion and diarrhea. Liver per se, no symptoms, but elevated liver enzymes and sometimes creep on till you have jaundice. So this is the presentation of the graft versus host disease of the mouth on the right, and the pictures showing some oral ulcers and this sclerotic presentation on the top right. And sometimes the patients can develop strictures. They're not able to open the mouth wide. The presentation is mostly dryness, ulcerations, pain, and irritation if you eat spicy or citrusy food, bleeding of the gums because you're not producing enough saliva. Tooth decay is faster, so you have to have a close follow-up with the dentist. When the food pipe is involved, the symptoms are primarily difficulty swallowing, painful swallowing, choking, and you develop strictures across the food pipe, which limits the flow of the food as a result of the chronic scarring of the muscles. And for the diagnosis, you have to do endoscopy, and sometimes we make patients swallow the barium and then take X-ray images to see where there's a kind of obstruction on the swallow of the barium. The treatments are the combination of the immunosuppressive therapies that we use, but at times we have to go back and forth again and again to open some of the stricture and dilate them. We don't see that this bad one on the right side that often, where you see that pipe is completely closed or stenosed. I think we have improved quite a bit in managing graft versus host disease than used to be in the early years, and with a lot more options available. But something we all have to be mindful of, that what it can lead to. Then once the stomach is involved, again, pain, weight loss, loss of appetite. It can be in both acute and chronic. Most of the time, we're good enough to pick it up clinically once talking to the patient, but very often we seek help from our colleagues in gastroenterology to go and scope and do the biopsies to rule out some other things before we subject patient to immunosuppressive therapy. And often we use combination of topical steroids and see if patient improve on that. And if not, we go with some of the systemic drugs to suppress the immune system. Gastroparesis, again, not often seen, but still once in a while we get to see some of these patients. And the fact what's happening is the delayed emptying of your stomach to the small intestine. And basically some patients will be having difficulty, inability to eat, and feeling fuller after each, on eating only a little food. And again, the same thing, we do the scan of the abdomen and see how long it takes for the contrast to flow downward to decide on if there's a delayed emptying. And the combination could be, again, suppressing the immune system using some of the drugs to increase the motility of the gut. And often some of the drugs to suppress the acid production, because a lot of these patients will have a reflux of the acid. And once the small and large bowel involvement happens, which primarily happens in acute, once in a while we see in a delayed acute or chronic. Again, abdominal pain, nausea, vomiting, because gut is not able to absorb all the gastric juices. All of this is coming out as a diarrhea. And if the gut is inflamed, you have this bleeding going on and weight loss because nothing is being absorbed. And but before we call anyone to have graft versus host disease of the gut, we try to rule out all the potential infectious and non-infectious causes that are still there, and looking out all the bacterial viral infections. And I mean, occasionally a tuberculosis of the gut, but happens in the right part of the world. And other causes still out there in inflammatory bowel diseases like Crohn's that we are aware of. We need to be mindful if someone has received a cord blood transplant. Sometimes the patients can have this inflammatory bowel disease as a result of cord blood, which is very peculiar to the cord blood only, and responds to the antibiotics. So have to be in a specialized center where they are aware of this entity. And again, the drugs that we sometimes use to prevent graft versus host disease, they can kind of start the cascade of this clotting, which can sometime form these microclots in the gut vessels, and the patients are presenting with the symptoms of graft versus host disease, but in fact it is what we call is thrombotic microangiopathy syndrome. So we have to be mindful of what we're doing here. And obviously other disease involvement of gastrointestinal system, and some of the medications, I mean antibiotics we use, they can cause diarrhea, chemotherapy can cause, and the CellCept that is often used to treat graft versus host disease can itself cause diarrhea. And again, the workup is, first obviously review all the meds and all the infectious causes. Then you pursue with the endoscopic procedures. And if depending on how much in more often than not, we can just do a scope on the lower part of the colon up to the what is called sigmoid colon and take a samples. And that in majority of the patients, it's very helpful, but very often than not, and that patients will have concurrent bleeding or some other pathologies going along where our gastroenterologist will have to go and examine the whole colon to look for the source of bleeding and stop it. And treatment again is several immunosuppressive options that we'll talk down the line. Again, liver graft versus host disease present as jaundice, but again, majority of the time, no symptoms. Most symptoms are coming from some of the concurrent GVHD in other organs that are happening at the same time. And it can happen both in acute and chronic, and most of the time, as I said, other organs are involved. And obviously, when we talk about the liver graft versus host disease, you don't jump on any liver enzyme abnormality to be a graft versus host disease. We review the medications. I mean, patients can have a fatty liver disease, ton of transfusions have happened, iron overload is there. Some of the infections that can happen among our immunocompromised population can contribute to it, and gallbladder inflammations can happen. So the management, do the ultrasounds of the CT scan, and occasionally we would need to do the biopsy of the liver when there is a mixed pathology, but we use it in the rare cases due to associated morbidity. And we rule out the infections, medications, and before subjecting someone to the immunosuppressive medications. And then coming to the IGVHD, I think very often than not, I think the patients will present with gritty eyes, but I have learned with my own experience that it starts very often with the patient complaining that they have increased tearing initially. And that is more of the reflex of the lacrimal duct to producing more tear before the real damage starts to present as a gritty eyes. And patients will have sensitivity to wind and sensitivity to light, and will eventually, if not taken care of, patients can end up having ulceration to cornea, which we don't see that often, because with all the supportive treatment available, we're fairly able to control it in a timely manner. So people use lubricating drops often, and they're available over the counter, but the suggestion is to use a preservative-free lubricating drops. And there are several topical steroidal and non-steroidal anti-inflammatory drops are available with prescription. And we work with the eye physicians and have them sometimes put the ducts, plug your lacrimal duct so that the tears are not going through the duct and preserved in the eyes. Occasionally, serum eye drops, which are made from the serum of the patients, can be used to help with the clinical, with the corneal to keep the integrity of the upper lining of the eye. And apparently it has some vitamins that can help, has some healing properties. And then there are some therapeutic contact lenses in some of the advanced form where other therapies have failed, has been found to be very helpful. But I often tell my patients to use the goggles, which may limit exposure to the wind and keep the eyes moist. Otherwise, they will be using the eye drops more often. And then the genital GVHD, I think this is the one that probably often gets missed because we probably don't talk about it much often. Either we're not asking or the patients are shy, but something needs most attention is as patients can present with again, like the skin GVHD as showed previously, there is a scarring of the superficial layer with the lichen planus and lichen sclerosis-like formations. You will have a vaginal dryness, painful intercourse due to scarring and ulcerations, patients presenting with a burning with the urination, primarily related to the formation of sometimes the strictures across the tract. And the management, if you pick up initially, we have very good success using a topical immunosuppressants or steroidal creams. But if it is still advancing to the strictures and so forth, we end up using the systemic steroids and combine it with some of the non-steroidal treatments. And we collaborate with the gynecologist and urologist because once the strictures are developed, we need to intervene with some dilatation and other procedures. And the lung GVHD, again, one of the very challenging graft versus host disease. And unfortunately, we find out about it when the damage has reasonably happened, because the patient presents with the shortness of breath, dry cough. So the symptoms started several months before that. It didn't happen overnight. So that it kind of creeps underneath. And by the time we see it as a presentation, and you will see that you're having decreased exercise tolerance, and eventually you will become dependent on the oxygen. And the picture, I'm showing you the two different spectrums over here. The one on the top is where there's obstructive presentation. Basically, what you see here, these are the dilated airways. They cannot, they have lost their flexibility due to this, the scarring of the walls of the airways. So air movement is kind of interfered over there. And the picture, what we have below is primarily is mostly how you will present a pneumonia, but this pneumonia is due to the autoimmune or immune pathology of the graft versus host disease, where the damage is within the airway rather than the outside. And the management lung function test, which can be very helpful because the obstruction is helping. Although the guidance is we do it standard for all the patients since it can kind of present, it can hide before it presents. So it's standard for us to do the lung function test at 1 year, but there has been studies shown that we can pick it up as soon as 6 months after transplant. So in a particular patients where I know that I have used some regimen which may have association with increased risk of chronic graft versus host disease, I tend to do it sooner. And then doing some imaging like chest x-rays, CT scans of the chest will be useful. Obviously, when you see those pneumonia-like findings, we go with the bronchoscopy, make sure there's no infection, because very often you have to suppress the immune system. And when you're doing that, the balance that you have to keep between the infections and the suppressing the immune system. And so the treatment is perhaps initially, if you pick up very early, you can manage early with inhaled steroids, inhaled bronchodilators. But if more often we are a little late in the picture where we kind of have to subject these patients to the systemic steroids and occasionally a combination. Some antibiotics have anti-inflammatory properties that we have to use. Again, using antimicrobials to prevent the infections as we are suppressing your immune system, and systemic steroids and non-steroidal treatment. And I think pulmonary rehabilitation, again, very, very important part of it. This is just a depiction of how we stage or grade your disease based on how much of the skin surface area is involved, what your liver numbers are, how bad your nausea is, how much diarrhea you're having. And that can give us assessment of the grading of the disease and give us an idea of how likelihood the response to the treatment or not. And this is, again, the grading for the chronic graft versus host disease, depending on which organs are involved and how severe your symptoms are. And that can give us an idea of dividing this between mild, moderate, and severe form of chronic graft versus host disease. Again, we have moved beyond just the clinical stages where we're looking at some of the blood biomarkers. Basically, in a group in Mount Sinai came up with this magic algorithm, and it uses a protein level in the blood of these two proteins called ST2 and REG3, which are derived from the gastrointestinal tissue, and the score is generated, and that score can be predictable of the response to the treatment and non-relapse mortality. And it's now commercially available, which we use often among the patients who end up developing it, but this is primarily for the acute graft versus host disease. Then intestinal microbiota, basically it's a whole colonization of the microorganism in the gut in a whole context of the things is called microbiota, plays valuable role in promoting our immune system. And there has been studies among the transplant-resistant patients showing the decrease in the diversity and presence of certain microbial species can impact the risk of graft versus host disease, failure to respond to the treatment, and non-relapse mortality. And there are several clinical trials currently undergoing to modulate the microbiome to improve some of the treatment outcomes. I mean, fecal transplant is one of the prime example of that it does work. And there has been a study out in Netherlands where they did the fecal microbiota transplant for steroid refractory graft versus host disease. And the patients received the fresh stool suspension from a healthy donor through the nasogastric tube. And 10 of the 15 patients who were not responding to standard of care treatment end up achieving remission. And then there was another study here in the United States where they gave fecal suspensions in the capsules primarily to prevent graft versus host disease. They have not seen any improvement in the clinical outcomes, but they were able to establish that how the stools, suspensions were given, they were able to establish the microbial diversity in the gut. And other trials, there has been some trials to prevent gluten-free diet. There was a trial using a Lactobacillus rhamnosus, and which did not show any reduced intensity of the reduced incidence of graft versus host disease. We at City of Hope did a clinical trial with the Clostridium butyricum to improve the outcomes among our patients, and and have seen some improvement in the acute acute graft versus host disease. And then we have currently ongoing trial using a genetically modified human lysozyme goat milk for prevention of graft versus host disease, where these goats are genetically modified to produce a high lysozyme content, about 60% of what should be in the breast milk. So basically, breast milk has shown to be helpful in preventing some of the diarrheal illnesses in the children. So sort of replicating the same concept, and they have treated the animals in the veterinary school with this milk and with some infections. And when they were fed with this milk, they have a faster clearance of infection and healthier guts. So we're trying to replicate see if the lysozyme antibacterial properties could be used to improve some of the complications related to transplant. Then treatment options for graft versus host disease. I think you need a whole talk about that, but I will try to summarize in this slide. Means steroids, systemic, oral, and intravenous prednisone. Some of you may have seen it. Topical, budesonide, beclomethasone, often used for the lung graft versus host disease, gut or gastrointestinal. Then the drugs like tacrolimus, sirolimus, Cellsup in several combinations. Ruxolitinib has really helped and has been approved for the chronic graft versus host disease. Again, then the Bloomsudol has recently been approved for the chronic graft versus host disease. Ibrutinib, again, has shown, was one of the first drug that was approved for chronic graft versus host disease. Infliximab, etanercept, these primarily were used when there is an advanced form of graft versus host disease or something that has not been responding to the standard of care treatment. And these are present in the intravenous formulation. And then photopheresis, and last but not least, I think clinical trials where possible. So this is just a cartoon depicting what the photopheresis mean. Basically, blood is drawn from the patient, and then it is separated, and plasma red blood cells are returned to the patient, but then the white blood cells are treated with the UVA radiation. And then these white blood cells are returned to the patient, and they, with the hope that they have some immunomodulatory properties or anti-inflammatory properties to impact the graft versus host disease. And we have seen some of amazing outcomes in some of the our GVHD patients. The only thing is it takes a little time to see the response, and you have to, it's a time consuming, you have to have a Hickman to get this procedure done. Occasionally, if you have really good veins, you can do through the peripheral vein. And obviously, when you have an extra line, risk for infections with the line. And initially, you have to come twice a week before we see the response, then we start to taper it. And I mean, graft versus host disease, that's the one spectrum, but it has all other spectrum that comes along with it, which not per se is graft versus host disease, but it's all the side damage that happens with the disease and the drugs. I mean, impact on the growth hormones with the lower production of pituitary production of the insulin-like growth factor. Thyroid dysfunction, about 40% of the patient will have a low thyroid function, and there is a risk of thyroid cancer among this population. I mean, about 2/3 of these patients will end up having diabetes in about 10 years from the chronic graft versus host disease diagnosis. And very often than not, those who are treated with the steroids like prednisone, they have seen these major fluctuations in the blood glucose level. As a result of these treatments, in decreased density of the bones with the fractures and contributing to impairment in the mobility, pain, and so forth, loss of the muscle, again, impairing as a result of the steroids and other treatments, impairing the mobility, impact on the cholesterol as a result of the liver graft GVHD or some of the medications, you can have major dysfunction of the cholesterol balance and a low production of the testosterone as a result of the treatments patients may have received or the chronic graft versus host disease. Then impact on the mental health, I mean, it's a major psychological distress of this chronic stressor that you have to live with, move from one phase to other and impacting, leading to depression, anxiety, delirium. And we have to be mindful of the patients, what they may be coping with and going through all these challenges. And impact on the quality of life, I mean, physical limitations, functional neurocognitive decline, impact on the self-esteem, impact on the sexual and other relationships because of the self-image challenges. And obviously, with the long-term treatment, very often than not, most of these patients with all these drugs are facing the financial challenges. So, I mean, graft versus host disease, to me, is a team effort. It's a complex disease, and it requires a close communication with the transplant team and the compliance with the treatment plan, which sometimes I feel like can be a barrier for several reasons. And outcomes have improved, I mean, since even I have started. I mean, Dr. Nakamura has been here forever. He can kind of probably has seen much more, but I mean, even since I've seen amazing improvement in some of the patients, and we're not seeing that advanced form of graft versus host disease as we used to see more often than before. And with the better supportive care available and emotional and social support, both from the team at your physician team and at the same time at home and the family, the friends, working with the dietitians to improve the nutritional challenges. I mean, physical rehabilitation, I think this is something we need to incorporate more and more. And I mean, polypharmacy with a ton of the drugs that come along with graft versus host disease. So have to have, and I mean, pharmacists on the team to guide us with all these drug interactions and prevent some of the major complications, and obviously a multi-specialty support as a result of these complications, not just from graft versus host disease, but some of the treatments that we offer. Thank you. Any questions? To some extent, with this, as I said, like some of the combinations of the drugs we use, I mean, one of the first slides I showed that we have to balance out the graft versus host disease against the relapse risk and so forth. So sometimes you're using the peripheral blood stem cells, but again, coming with the increased risk of graft versus host disease. We could have used the bone marrow graft, the lesser graft versus host disease, maybe slightly increased relapse. And some of the drugs that are being used to prevent graft versus host disease may have amazing outcomes in regard to acute graft versus host disease, but the increased chronic graft versus host disease. And if you have a mismatched donor, again, the risk of chronic graft versus host disease suddenly goes higher on that end. So it depends on, it's not like one factor, but depending on multiple factors, we can gauge that what patients may be at the high risk down the line. And someone who has acute graft versus host disease will likely be a higher risk to have a chronic graft versus host disease. So we have to be cautious again, like in about 6 to 8 months, we try to taper you off the immunosuppression. And that's where the most of the relapses of the recurrences of graft versus host disease happen. But let's say if you have a low risk disease where I feel like your relapse risk is lower, then I don't have to be so fast in tapering you off and can keep you on some lower immunosuppression over the 1 year period or 2 year period till I'm confident that the host that we have got tolerance toward the donor cells, and then taper you off. Exactly.
And what percentage of people, it sounds like almost everybody.
Absolutely. Majority, I mean, as I said, like one of the slides that I showed initially, about 60% of the patients with unrelated donor, which is a major chunk of the donors that are being transplanted with, are having graft versus host disease, 60%. Yeah, yeah, yeah. Yeah. I think, truly saying it, as I said, like, my first guess will be about 6 to 8 months when I taper you off. If you did not, about 6 to 8 months when I taper your immunosuppression, that's when I'm gonna get like a first sign of if you're gonna develop chronic graft versus host disease or not. If you develop it, then perhaps you will be on a longer immunosuppression to prevent it. It perhaps may not be that intense, but enough to keep it at bay. But let's say if you did not have any graft versus host disease till 2 years, likelihood is very low. I mean, have I seen beyond 1 year? Yes, I have seen it in someone who did not have it, but likelihood is very, very low. Absolutely. As you see, I think the most of the audience here is with the some with the MDS here, and very often MDS is the disease in the elderly age group, and very often than not, the donors are in the same age group. And there has been studies showing in the stem cell transplant from those donors may be associated with the higher chronic graft versus host disease. Yeah.
Any more questions?
It's going very well. No, it's almost, I think we should finish it soon. So it's definitely a challenge to to tell patients that it's a medicine, not a milk. Like at the end of the day, it is being used as a medicine, but it's a cool concept and a great collaboration with the colleagues at UC Davis who have invested in it a lot. Thank you.
Thank you so much. Thank you so much, Dr. Sandhu, for sharing your time and expertise with us today.